You are currently the only person in this conference.
And I'm going to say good morning to everybody. How is everybody doing this morning? Did you guys have a good night's sleep? Coffee at the ready, of course. It's a beautiful day in Whitby where I am. Is everyone having a nice sunny day? Oh my gosh, I'm in deep. Oh, and let me share my camera so you guys can see me too. Oh, thanks, Anita, for getting up so early for me. All right, so you guys will see I have posted a couple of things that you guys asked me to put up. I don't know if you had a chance. I'm sure Anita was just rolling out of the bed this morning and she is with a cup of coffee in her hand. Um, but I have posted a couple of things. I posted links. I also have posted a discussion that I would like us to spend more time on. And the reason I have done this is because I want us to give an opportunity to you and me to spend enough time on a topic that I know for a fact is going to be on your CIC exam. And we will take our time to take a look at COVID, SARS, and Ebola. So we will discuss in a more detail in our discussion session there. I'm happy to have you contribute in any fashion you feel right, but I want you to get an understanding of what are these organisms, how are they emerging, what are the transmission modes, and how do we manage them in healthcare system across the continuum. So there's going to be a little bit of a difference in terms of how you're looking at some of these diseases in acute care setting versus long-term care setting. So I think that's what I wanted to touch base on. I also uploaded 2 forms for you. I know Burnett was actually asking for that last week, and I forgot to upload that. And I'm creating one of these line lists for you, and I will be using your names in there. So don't get shocked if you see that you have some incurable disease in the line list. So I will upload that once I get that sorted out. So you can actually see pivot tables and how do you use these line lists to extract reports. So that will take me some time to enter fake data in there because I want to have enough data points for you to see. And then that's what's going to be also shared with you shortly. So I just want to ask you guys if you have any questions from yesterday. No? No questions. Okay. So I think we can start. If you don't have any questions, can everybody hear me and see slides correctly and right? Yes, yes. Okay, good. All right. So good morning. I just wanted to share my cup with you because I know Amandeep was asking me what hat I'm wearing today. So today I decided to have no hat, just my cup. All right, so let's move along. So we are continuing with the session from yesterday. As I said, it is a fairly large section that we need to cover. It's not going to be running in great depth. I will be highlighting things that are important for this course and things that are important for you to be revisiting when you're studying for your CIC course. So This is where we stopped yesterday. So we are going to continue with our anaerobic non-spore-forming gram-positive bacilli. So you will find that when you get your results from the labs, you will find that some of these microorganisms are going to be listed. I will tell you, I have never come across any of these, especially lactobacilli would be something that is not something that we find in our patients quite commonly. It is a part of, obviously, you can see a normal vaginal flora. With some of them are normal skin flora. So they're really not something that we see in results, but do make a note of these organisms. I also haven't seen them being mentioned in the exams. They can sometimes throw them to you as a trick answer usually, but it's not something that is running around in any major numbers that has a significance for us as practitioners. So now, oh my goodness, I cannot spell obviously. So antimicrobials and resistance, I apologize for that. So we touched base yesterday a little bit about the antimicrobials and resistance. So with the use of antibiotics and antivirals and antifungals, you will find that over the course of time, many of the microorganisms have developed ability to fight the antibiotics or antimicrobials in a broader sense. You will also find that we have almost entire chapter in IPAC world as a practitioner that we dedicate fighting the antimicrobial. So that would be a part of your antimicrobial stewardship. There is entire session designated to antimicrobial stewardship and importance of defending the last line of antibiotics by limiting usage and controlling how are we prescribing antibiotics. But so what I want to go back to is to talk about what antimicrobials are. So when you're looking at them as medications, they're there to either inhibit the growth or kill the microbes, and they're prescribed to fight viruses, bacteria, fungi, and parasites. So with most of them, you will find that most antimicrobials are administered through intravenous route, but also can be oral prescription. So if you ever had any sore throat, you had visited your physician, they give you oral antibiotics often. In hospital settings, in healthcare settings, in acute care settings, you will find that we tend to give our patients IV antibiotics. And it can be also introduced into the organisms through a little bit different and novel approach. It's sometimes you will find devices that are introduced into sterile sites that are actually coated with antimicrobials. So some of those would be like your orthopedic hardware, like artificial hips and knees. But also you will find this with the endotracheal tubes and urinary catheters. And there is also a little bit that comes with orthopedic surgeries that I'd like to just highlight for you and prime you for future sections. There is also a part of treatment that we do also put our patients prior to surgeries into prophylactic treatments. So your antimicrobials can be obviously in line with what are we trying to treat. They're bactericidal or fungicidal, and they do have the role of killing the organisms. That's the goal. Some of them are actually bacteriostatic, which means that they will slow the growth and not necessarily clear the infections, and also depends on the dosage or the duration of use. So it's critical when we as patients are prescribed antibiotics that we take a full course of these antibiotics, because the interruption of the course is actually what breeds the resistance in microorganisms. So when you're looking into the mechanisms of how the antibiotics work and or don't work. So when you it's important for you to know this. I will just say, make sure you know how the antibiotics are entering the microorganisms, but also how these microorganisms are learning to defend themselves from these drugs. So this is how the entire antimicrobial world is actually working. So when you're looking into your cell wall, you are looking into different types of antimicrobials that we are using to penetrate that cell wall. So there is your penicillins, your vancomycin, and echinocandin. Then you are looking into your cell membrane, and so all of these are designed to attack this particular part of the microorganism. So there's your cyclic lipopeptide and triazole, and then for ribosomes, you're using macrolides and aminoglycoside and tetracycline. So to answer your questions, I know you're going to ask me, is there going to be a question identifying and asking us to know which of drug is responding to what particular part of the microorganism? Not necessarily. However, what you may have been asked, it's mostly going to be presented in the body of your question. And then you have to know what kind of defense are we looking at. So if you're looking into some of these metabolic pathways, so there is going to be very unique organisms that you need to know. For example, we are going to cover this as we go through this session. So how does CPE work, or how does TB resistance work, and how are these organisms smartening up, or have they always been smart and we are just catching up with them? So to know what is the current state in your hospital or in the region that you live in, it's important that you grab these antibiograms. The antibiograms are usually created by your local laboratory. Could be your own hospital laboratory if you are in a larger hospital center, but usually your external laboratories are running these antibiograms. And you can actually Google antibiograms and see that across Canada, it's not the same resistance developing across in the same rhythm. So it's, and also changes through the years, changes geographically. So what is important for you is to have these antibiograms readily available for you, and you can see what antibiotic will work. Usually your infectious diseases physicians are using this. For you as an ICP, it's important that you know that this does exist. Kind of get familiar. You will not be prescribing any medication, so you're not going to be the decision-making individual on this, but it's important for you to know what is happening in the area, so you can also be aware of what can you see entering your facility, what could be the challenges from the PPE perspective, spacing perspective, so you know what you can expect. So the antibiograms themselves, they're usually developed on annual basis, or at least reviewed on annual basis. And but what that is actually they're running the reports after they're done all the susceptibility tests. So they have a bunch of microorganisms. So say they're running Staph aureus susceptibility, and they want to tell you how well would some drug fit. And reason for it is, again, is to be successful in the treatment, take less time to treat a patient, but also ensure that we are not developing more of the resistance among these organisms. So it is usually, as I said, used by the physicians. Your infectious diseases physicians and pharmacy will be a big part of this decision making. And you will see, you can find them on You can find these antibiograms sometimes in your public health labs. They have them. And if you actually go in, if you have a lab on your site, if you go to the um, any of the lab technicians and ask them for the antibiogram, usually they come on little cards. I can't find mine where it is, but I had one that is kind of like a fold card, and it just gives you a printout of the microorganisms and what is the drug of choice, what they're responding to, and so on and so forth. All right. So when you are looking into these tests, how they're looking, whether actually how they're completed, you can see on the picture that I have uploaded here for you. So they're putting these little wells with the actual antibiotic in this particular case on the bottom of the well, and then they're introducing the anti sorry, they're introducing the microorganisms, and you will see how whether they're growing or not. And if you have growth in any of these, it means that they're not responding to antibiotics. So this is, again, not for us to interpret, it's only for us to see how this looks in real world. Hopefully that helps you comprehend and understand how these tests are done and how the lab runs them. Sometimes you actually are, if you're lucky enough, you can go to the lab and see they're doing this. But it has a huge impact across the globe. If you're looking into countries that have been severely impacted by the antibiotic resistance, couple of countries that come to my mind is India, Israel, Greece, Spain. So, and what is unique for these countries is that they actually have access to antibiotics over the counter, and people are just going in and I have a sore throat or I have sniffles, and they're buying antibiotics and somewhat self-medicating. Israel has done a really good job with managing their antibiotic resistance over the years, and it's becoming a poster child for most of us fighting, looking at how did they reduce the number of their antibiotic resistance. So I can share some of the documents that you may find interesting. Again, nothing for you to study for CIC. It's just to know that there is world spread antibiotic resistance. It is happening for many reasons. One of these reasons is access to antibiotic. A couple of other reasons include also the animal husbandry, and there's thoughts that also, of course, that there is inherited resistance within the organisms. So if you are to, I think Anita posted a video where you actually can see these plates being shown to us. So what it is, you will see in a petri dish, there is usually the media, and then they put these little antibiotic pills, and then they plate with the microorganisms. So wherever you have this um, the wells around the zone of inhibition, it tells you that there is a resistance, right? So they're not, the bacteria is really not actually able to grow there. So when you're looking into, you want your antibiotic to kill the microorganisms. So whenever there is nothing happening around there, you actually know that there is a problem. So how does antimicrobial resistance happen? So it's actually a naturally occurring phenomena in the microorganisms. It is linked to overuse, misuse, and inappropriate use of antibiotics. When we are talking about the overuse, this is where you see people are prescribing way too many antibiotics for situations where antibiotics are not necessary. So I would think of situations where you have a viral infection and a person is prescribed antibiotics in in attempt to cure whatever infection is going. Misuse is also another example, but I would say it's predominantly is when we are over prescribing and not finishing these treatments is a big chunk of the contribution. So when you're looking at some of these causes is also a delivery of more complex healthcare. So when you're looking into the surgical procedures where we are intentionally placing our patients on antibiotic treatment prior to surgery and post surgery to prevent infections from happening, because some of these surgeries have been invasive. In some instances, you will also see that in case there was an accident or bowel perforation, we are putting our patients, of course, on antibiotics so they would not end up with significant infections. Another issue also is your prolonged hospitalizations. So we touched base yesterday on when we were talking about C. diffs, and usually people will come with pneumonia or appendicitis or something like that, and then we put them on antibiotics, and then they develop C. diff. Now that C. diff is requiring hospitalization frequently on its own, so it's a cause that we are keeping our patients for extremely long time in the hospitals. In some instances you will find with CPE infections, that's quite an ordeal to deal with CPE infection for the patient predominantly, but also for the physicians and pharmacists, because of the limitation of drugs that we have to treat. And as you're getting into more resistant organisms, to treat them, the choice of drugs is usually highly toxic, and it causes actually kidney failures, liver failures. So it is a very fine line, and sometimes a battle we don't win, unfortunately. So Anita, you're asking, is there ideal practice that we use when in case of infection? Do you wait for CNS result to start antibiotics right away? So in a acute care setting, that's not a practice. So usually what we do in acute care setting is when someone enters a hospital that we are suspecting infection. So based on the clinical presentation, so if a patient presents with something like a respiratory infection, or it could be a gastro, or could be urinary tract infection. So based on the location, we are starting them empirically on treatment, and that would be a broader spectrum treatment that is geared based on the clinical presentation and location of the infection. But also you want to collect specimens before you start the treatment. So usually we are looking for blood to be collected, 2 specimens, so we can run 2 cultures to prove whether there is any bloodstream infection or so on, or if it's sputums that we are collecting. So you'll want to collect specimens before you put them on, or even on the empiric treatment, because there is always a risk that you will actually get a false negative because we started the treatment. Did that answer your question? Yes. Okay. So, and then where were we? So, prolonged hospitalization. It does also. Another thing that that I would like to highlight to you is the medicine tourism, medical tourism. So people actually will leave Canadian soil for procedures outside of country. So you may end up actually someone coming back with um, antibiotic resistant organisms due to exposure at other hospitals. So most common ones I would think would be your plastic surgeries. People are going down to Brazil to get some of the plastic surgeries done. Quite common is Mexico. You will find that. Mexico is quite frequently visited for dental work. A couple other countries that people are going for plastic surgeries and dental work include some of the European countries. Croatia comes to mind. So they actually have developed entire tourism package around it where they come and pick you up from the airport. You go have your procedure, they place you in a hotel, and then during the recovery they ship you down to the Adriatic coast to recover. That said, that's something that puts us at risk, and I find probably more in the States would be something that you would see due to limitation of their insurance and access to healthcare. It would be something that is more commonly done from the States perspective than from us. And this is something that you probably will have a question on your CIC exam, talking about some of this medical tourism. Not too many questions, but you may have a question. So what are the risks for us when we are looking from the IPAC perspective about these microorganisms? They do tend to spread through our units and through our facilities. And if we don't stick to the rules and measures to control them, they will take over. It also can be a big issue for your ICU settings. It can be a big issue for your NICU settings. So something to be aware and cognizant. And this is why we ask for screening and pre-screening, pre-admission screenings to be completed. Through COVID, we actually have significantly reduced the number of tests. So there is that risk also happening, that we may be brewing or spreading some of these resistant organisms unknowingly because we are not monitoring, because labs could not be processing as high volume of specimens that they were dealing with. So some of these routine tests have just fallen off the screening. You see, Vernette, this is what happens. And then they come back with cute little behinds and an infection.
Definitely, definitely.
All right. So I don't know if you guys have seen, it's not really an infection control issue, but a couple of years back, there was this young lady. She was using her basement to introduce the silicone in people's back ends, and she was using the construction silicone, not the medical grade silicone. So people ended up with concrete behinds. Not an infection control issue per se. I wonder if she actually had any in her basement that she followed, but this is a different topic. So anyway, go back to our antibiotic resistance. So it is intrinsic to bacteria. It also can be acquired. So you will find that some of the bacteria have these natural defenses as a part of their makeup, but it's also something that we have propelled through the years. So it could be through modification of use of antibiotics, the enzyme production. So I have highlighted that because it is important for your CPE microorganisms. So that's the family of the microorganisms. We will touch base on that a little bit more, getting a little bit more in depth on that. And then also the way they're working is actually preventing your antibiotic from reaching the target. So this is important to know, that some of these microorganisms have learned a skill how to prevent the antibiotic from reaching either that cell wall that we were talking before, or reaching that cell membrane, or reaching the areas that they need to. So I just flipped back to show you that some of these antibiotics cannot get there because the microorganisms learned how to prevent this from happening. So they can also decrease your cell permeability or affect the active transport out of the cell. So they actually can, as you see these antibiotics being pumped into the cell, the microorganisms just pushes antibiotic out. So it's kind of neat if you have an opportunity to see this. I'll see if I can find some of the videos how it shows you the mechanism of actually microorganism pumping the antibiotics out. And then there is also the modification of the target. So they're smart enough to create these binding proteins or ribosomes or chromosomes and change the cell physiology. The acquired mechanism, it could be either vertical gene transfer or horizontal gene transfer. So there is a picture for you that is a little bit simplified in terms of how does the mechanism actually work in a little bit of a more of a lay term, I would say. But you can see that they either can develop a cell process that just prevents the antibiotic from reaching the target. Then you're looking into these antibiotics that create enzymes and they break down your antibiotics. So that would be your CPE in particular. And then you have these ones that restrict access by changing the entryway. So they're just smart enough, they just close their entrances and the antibiotic cannot penetrate through that cell wall. And then the one on the right bottom, it tells you how they're actually pushing the antibiotic out. So those are some of the means of our little bugs being smart and smarter than us sometimes. So the mechanism of resistance, there are 4 different ways how they develop resistance. So there is a drug inactivation, a change of target site of drug, change of metabolic pathway, and decrease in drug accumulation. So this is when that's when they're pushing out your drugs. So I'm going to urge you to take a look at this slide and make note of a certain mechanism and then an example on the other side. So this is important for you to have some of these ideas on how the microorganisms work, and what you can pick an example here. So the ones that do restrict access of the antibiotic, so those are your gram-negative bacteria, that they have the outer layer and that protects them from the environment. So they actually have ability to defend themselves from antibiotic even entering the cell. Then when they get rid of it, they use these, they call them pumps really, and they're pumping out your antibiotics out of the cell. So some of the examples would be your Pseudomonas aeruginosa. And with Pseudomonas, that's the one that is a water-loving organism. It is quite commonly found in patients that are intubated in ICU, so now the part that is, they can ask you a question about what are the organisms that you could be suspecting when you have a patient that has an infection, they're intubated, so that's one of the that you would think of. And also they can ask about what are the risks and what would be the measures that you would be putting in place to prevent infections from occurring. So you always want to talk about your RTs and have a relationship with them, review their policies in regards to changing and how frequently is the water replaced, what happens if we have any condensations on the tubing, and more of a discussion around the prevention of that Pseudomonas growing in the water. So what is your role as IPAC? Then how they change and destroy the antibiotics. So that again, your Kleb pneumo, you will find that one to be also developing ESBL and CPE resistance. So that's how they learn to destroy by creating, and they actually have the enzymes. And So once the antibiotic is inside of the cell, they produce the enzymes that break down the antibiotic. So it's completely ineffective for them. So some of them would be your E. coli, Kleb pneumo, Citrobacter fruindi. There is about 70 different organisms in this family that have ability to break down the antibiotics. And then how they bypass the effects of antibiotics, so they just develop a different process. So they're preventing your antibiotic to enter the microorganism. So a good example for that would be your Staph aureus when they prevent antibiotic from entering. So that's how that mechanism works. And then when they change the target for the antibiotic, so they're kind of smart here. So that would be your E. coli, and when they're developing the resistance against the colistin. So the colistin cannot latch to. All right. So something that is, when I was studying, this was quite shocking to me actually. But if you think about the history, the penicillin was actually discovered in 1928. And then the first penicillin staph was actually identified in 1940. And on that little picture to the right, you will see how what antibiotics were introduced. So if you look at antibiotic resistance identified was in 1940, but your antibiotic introduction actually happened in 1943. So they actually developed resistance before we even brought penicillin on the market properly. So you can see through this timeline that we have Shigella that was developing resistance in 1959. Methicillin was identified in 1962. So MRSA has been around the block for quite a while, as you can see. Then you're looking into your enterococci that have been identified in 1979, and as you're looking down in 2000, there is the tuberculosis that is also resistant. Then we are going into the Staph aureus that is vancomycin resistant. So now we have not only MRSA, we have um, VRSA, and there is really no end to it. I really don't see that we can pump more antibiotics and expect that the microorganisms will respond to it. They're smarter than us, no matter what we think. You guys good with this? Can we move along? All right, so I'm just going to tell you a little bit here of what are the contributing factors and what are the selection pressures. So when we are talking about overuse or misuse of antibiotics, usually we think about clinical practices in humans, and then the next big thing is agriculture. So that's why I mentioned this before. It's the animal husbandry, where the practice is to provide animals with antibiotics, and it does enhance the growth of the animals. In Canada, we have a very strict regulation speaking about use of antibiotics in animal husbandry. So we are sticking with the veterinary treatment. So in case where animal does need to be treated, of course they are treated. And then going back into the slaughtering process and going back into the food chain, they actually have to be off antibiotics and antibiotic free before they get slaughtered. So you will not find in Canadian meat antibiotics. So every time you go into the store and you see it is a Canadian product and it says antibiotic free, it's a sales gimmick, because all Canadian meat has to be antibiotic free by law. The difference is when you're buying meat that is introduced into our market and coming from other countries. And so that's something to be aware of. But for Canadian product, it's just a sales gimmick that they put on. It's an advertisement for you to spend more money. So it's no different than any other meat sitting next to it that doesn't have a label antibiotic free, as long as it's Canadian. So, and then other thing is also that veterinary medicine. So when you're looking on the use of antibiotics in a global scheme of things, looking at into world, there is only one country that actually has deemed their chicken to be salmonella free and antibiotic free. And the way they actually approach that problem is by culling their animals. So every time they would find a salmonella in chicken, instead of treating that chicken, they were culling the entire flocks of animals. So it's Sweden, if you're interested in that. In Canada, we actually consider all our chicken to be at risk to be contaminated with salmonella. And for that reason, again, we are not treating the animals unless they're sick, and we are not necessarily culling these animals either. And then a couple other things to think about is also recirculation of antibiotics. So whatever enters our water system, how does that enter the food chain? Are we actually able to break down antibiotics through the processing, and what's the half-life of antibiotics in the water, and how quickly does that turn around? So that's with regards to our selection pressures here. So with the example in particular here, it's a penicillin resistance in Staph aureus. So if you remember that timeline I showed you before, so it is developed in 1928. It's discovered rather by Alexander Fleming. And then in 1943, we started using penicillin widely. And the first penicillin resistant Staph aureus was documented in 1947, and then methicillin resistant in 1961. So now they're saying it's approximately about 40% of Staph aureus that is actually MRSA in Canada. So what it is, and how it works. So as I mentioned yesterday, I don't know if you guys remember, it's about 60 to 70% of general population will carry regular Staph aureus on skin. It is a part of our skin flora. It's nothing to be concerned that we have it. It's simply part of who we are. The problem becomes when we start carrying the MRSA. So when we start picking up on that methicillin resistant Staph aureus, or do we actually create it ourselves through use of antibiotics? So you will find that again, the colonization is not a big deal. With MRSA, the problems do become more evident once you're looking into the infections. We do not treat and decolonize people with MRSA colonizations. It's been a practice in the past, but it is not recommended anymore for the plain reason of developing more resistance. So sometimes you will find there are instances where you would treat a colonized patient that are at risk of getting infections, and patients who do have a high frequency of these infections. So I remember one particular patient in my hospital, she was a dialysis patient, chronic diabetes, and had several surgeries. Some of them were limb removals due to gangrenous infections in her case. And she was absolutely a huge risk for us for infections because she was a known colonized MRSA, and we were treating her colonization. And that is usually done in a conversation with your infectious diseases physicians, surgeons, and so on. But generally, we do not decolonize people because of the risks of, as I said, growing more resistance. So it's more and more resistant to methicillin, but there is some that are actually responding, and that would be your sensitive or susceptible Staph aureus. You will find when you're looking into your healthcare associated cases and community associated cases, it becomes really challenging for us to distinguish what came first, the chicken or the egg in this situation. We don't actually often know whether the ones in community leaked out of the hospital, or did we bring the community strains into the hospitals and vice versa. Usually when you're looking into your MRSAs, they tend to have quite high fatality rate. Of course, then your methicillin susceptible Staph aureus, for the very simple reason they do not respond to methicillin. Also, when you are looking into your outbreaks, something that I would like to highlight here for you, when you're looking into outbreaks such as, for example, C. diff or influenza, there is a very clear set definition in terms of uh, what is an outbreak in this case. However, for your colonizations and infections with organisms such as MRSA and VRE and CPE, you will have to calculate your baselines, and you want to compare your numbers from this year to previous years to benchmark and see whether there is an increase or not. So sometimes it can be misleading when you see a couple of cases coming through and you think that suddenly you are actually facing an outbreak. You have to calculate these rates. There is no other way around. You have to take a look back and determine whether there is a true increase or it's just a fluke that you're seeing. So, Marina, so with MRSA, depends on a hospital setting or a long-term care setting. The recommendation is to have our patients swabbed. So, generally speaking, once you are positive, there is about 20% population that will be permanent MRSA carriers, and the rest of the people tend to be intermittently positive or negative. So it is a little bit unclear whether people are prone to picking up this particular microorganism, or are they actually developing their own, and their own flora is creating this resistance due to use of antibiotics. I used to have a couple in one of my facilities, and they shared a room. They were married for 50 plus years. They shared a room, shared a bed. One of them was positive and one of them was negative. So there is really not clear how this partner never got MRSA, where the one of the partners was uh, constantly positive. So when you're looking into the isolations, usually what happens once you're positive, your acute care settings do put flags on the patient's charts. Those flags are unique to the particular facility. They can travel sometimes, but usually you're looking into the results that may be outdated. Sometimes you can access some of these common databases and take a look. And depending on a policy, so you will have some facilities will say, once MRSA positive, we always treat you as positive. Some will actually consider that after a certain period has passed and a certain number of negative swabs has been collected, you're deemed no longer colonized. That said, when you are swabbing your patients, if you decide to go down that route, you have to make sure that patients are not on any antibiotic treatment during the swab collection. And so yes, so with the contact precautions, again, there's different approaches to contact precautions with MRSA. In most instances, you will find the mask, and the reason for it is that it actually you can introduce as a healthcare provider the MRSA to yourself as well, into your nasal passages and so on and so forth, and vice versa. You as a healthcare provider can actually create more issues for these patients. All right, ready to move along to another organism? Okay, so VRE. It is your vancomycin-resistant enterococci, and there is two most common strains that you will be finding in your results. One of them is Enterococcus faecium, and another one is Enterococcus fecalis. They have become resistant to antibiotic vancomycin. Since about 2012, there is some facilities, I mentioned this yesterday to you guys, that actually have stopped isolating VRE because on a grand scheme of things, in comparison to MRSA, wasn't so high in infections, and the fatality rates were not as high in case of a VRE infection. However, after these hospitals have stopped isolating patients who are positive for VRE, we have seen a spike in infections. So we are talking about isolation for the colonized patients. And then PIDAC came out actually recommending and revising their recommendations, suggesting that all VRE positive patients should be on additional precautions. This would be your contact precautions. So that's, I'm going to tell you a little bit. I had a case of a VRE outbreak. So I had 2 units. There were 2 sister units in my portfolio, and on the cardiac unit we had a case of VRE, and that patient was known VRE, so it wasn't a healthcare associated case. He was admitted already with known flag, and we put him on precautions. What happened a few days later, we had couple other patients test positive for VRE. So from epidemiological assessment, usually you don't know what who gave to whom any of these organisms, but they were in neighboring rooms. So through the epilinks and looking into your geographical connections, it was assumed that this would be a transmission of VRE from our index case that was an HAI. And so we ended up having quite a number of patients in this particular unit positive with VRE. And what happened actually was really interesting. So their neighboring unit, the sister unit that is also medicine floor, they didn't have any cases of VRE on the unit. And one of our patients that was there for extended period of time, we swabbed her. She was coming up on her monthly swabs, and she was also tested positive for VRE. And now that was more concerning because this particular case came out of nowhere, and we couldn't figure out where did this VRE come from. So in a conversation with this particular unit, I was asking them what kind of procedures did we do on this patient? Where did she go? And at this point, no one really could think of anything in particular that was standing out. But in the afternoon, the charge nurse calls me and she said, "You know what was I thinking about? We were actually scanning her bladder, and our bladder scanner is broken, so we borrowed it from the other unit." So I start looking and reviewing all our patients' charts with all these VREs, and sure enough, all of them had their bladder scanned. So then I had to go back to the bladder scanner and see where that bladder scanner went around the hospital, and actually was that bladder scanner used on these particular patients. What I've learned is that there was one bladder scanner that was used across the entire facility pretty much, well, at least within the program. So the same director was managing these programs, and it was that the bladder scanners were breaking down on the other units, and she just would say, oh, you know what, they're on back order, just go and use from this particular unit. We actually ended up having outbreak across the facility, affecting the original floor, next floor to the right, a floor above, and 2 floors in a completely different wing. Again, for the same reason, it's that same bladder scanner that was traveling across. And what we actually found out was more revealing to me, and something that was shocking, that our index case that we initially thought was a cause was not even related to any of this. And we actually never found the cause. So when you start looking into the genome makeup, that's when we figure out that the rest of them were all related, except that case that we thought was our index case. And then the outbreak carried through few units. It affected 3 different units. And we have been doing some of the environmental collections and found the same type and same genome of VRE in the med carts and in the WOWs, so the computers on wheels. So the nurses would have on the computer on wheel, they have usually these little boxes where they keep the medication. Sometimes they have some small supplies there, like alcohol swabs, or sometimes they put their pens in there and whatnot. And really, it's not that greatly clean. So when a nurse comes in a shift, they usually tend to clean the keyboard and the workstation, but those little drawers, they often get forgotten. So that's where we found a bunch of the VRE. We found VRE in basins. We found VRE also on the packs, the cardiac packs. So it just kind of opened our eyes in terms of how true are these epi-links, and it's only what you see, and you can only make a decision on what is in front of you. And once you actually have ability to see a broader picture, it can change the way your sources are seen, your management can be done of these organisms and the outbreaks. Yeah, it's actually quite exciting, when I always like this piece of our job, that is that investigative piece, when you have time to sit down and take a look at the results and take a look at patient charts and find these connecting pieces. But as you hear from me, it would never dawn on me that this was a case unless I had a conversation with the frontline staff and they were willing to dig through their own memories and actually help me find the problem. I would never think of it. I wouldn't. So next organism is ESBL. It's actually a family of the microorganisms. Most common representatives would be your E. coli in it, and you will find your Klebnumo in it. So what it is, it is microorganisms that create develop an enzyme that does inactivate the antibiotics. You will find a different approach to these across the board from a facility to facility. Some facilities do not isolate at all. Others will isolate only for clinical specimens. So if your patient tests positive for ESBL in urine and they have a catheter in, that's who gets isolated. And for some other facilities, they isolate all ESBLs. How that decision is made is usually you have to have your ID physician and your IPAC team sitting and making that decision based on the risks and also on availability of rooms. So if you are struggling with a space to provide to patients, you're looking at who and what has a higher risk really of spreading, and where are your the biggest wins, really. So you don't want to cohort your influenzas, but ESBL can be managed, and it's not that, in the grand scheme of things, it's not taking that big stage like your MRSA or CPE with mortality rates. It still does respond to some of the antibiotics and so on and so forth. So CPE, and I used to say new kid on the block, new kid on the block. I don't want to call it that anymore because it's been around quite a bit and it's been talked about quite a bit. It is becoming more prevalent in Canada. You will find certain parts of Canada have a little bit more challenges with this. In particular, I'm going to point in direction of BC and also Nova Scotia, and then parts of Ontario. And what that is, it is actually a family of microorganisms. They're called carbapenems producing enterobacteriaceae. I find it always so mouthful to even break it down to what it is. It is across the globe present, and our first experiences with CPE were imported cases, and then through the time we were kind of seeing some of our own homegrown cases, but again predominantly in acute care settings. And now it's pretty much everywhere. You can find that long-term care facilities are having their own, retirement homes are growing their own, and it becomes an issue. So it is a huge problem from the treatment perspective. The mortality rate in case of an infection is 50%. So what is here today is 24 of us in this classroom. If 24 of us got CPE infection, 12 of us would die. And that's quite significant when you're looking at the number of the fatalities. I have had a young gentleman come into our hospital. At first, we really didn't know what's going on, had rather odd symptoms presenting. Came in January, he was really, really hot, was shoveling snow and showed up in shorts and tank top. He was just could not cool down, so we really didn't know what's going on. And to be quite frank, from that perspective, wasn't really a big issue from IPAC. Didn't really look like anything that we would be interested in, and only to find out later on that he actually had a CPE in lung, and at age of 40 he passed away because there was nothing that could be done after everything said and done with treatments and different cocktails that the pharmacy and our ID physicians were cooking up for him. He was going from mild improvement to kidney failure, is putting back on treatment once he recovers, back to liver failure, and eventually he sadly passed away. The CPE itself has the enzyme that breaks down the antibiotics. So they are ertapenem, imipenem, and meropenem. That's what they're breaking down. And when you're looking into your CPE classification, most common ones that you will find are KPC and NDM. And those are actually have been imported, as I said. You are looking into New Delhi, the NDM. So they're named after the countries where they were first identified. Where do you find these microorganisms in your healthcare setting? Is they're water-loving organisms. You will find them in P-traps. So this is why I have this picture of a sink here. So if you want, you can take a look under your own sinks, and there is this pipe that is in a shape of letter P, and that pipe is primed with water to prevent the gases from backing from the sewer. However, what we find is that in these pipes, especially in settings where we are draining organic materials down these sinks, such as IV bags or coffee drains or if you're washing dishes in hand hygiene sinks, you'll find that the biofilm gets created, and that biofilm is what these microorganisms feast on. So if you're looking for a CPE in your facility, you have to connect with your lab and tell them you are collecting environmental specimens so they can cook up a different broth for you and send that for testing. And then what you do is you take your swab, the culture swab, usually the long white ones, not the nasopharyngeal swab, but the ones that you would be using for MRSA or VRE, and you go down the drain and sweep around, and you want that gooey black gross things on your swabs and send that for testing. I don't know how many of you live in around Toronto area, but St. Joseph, the hospital downtown Toronto, had a huge issue with CPE. They actually ended up removing plumbing from the walls, so they were going beyond the sinks and cutting the pipes about a meter in all directions to cut back and remove that bioburden that's growing in the sinks. And how does this creep out, one may ask? So when we are cleaning our hands, or when we are in the shower, usually what happens is that's back splashing back from that pee trap at us. So you think, oh, I clean my hands, but what you actually done, splash that back on your hands, and now you're spreading it further. So one of the things that I find most difficult and most challenging to bring home is do not drain IV bags into these sinks, because the IV bags have enough nutrients for the microorganisms to grow. And another thing to keep in mind is that they tend to be also intermittently present. So sometimes you will swab and find the microorganism there, and sometimes you will swab the same sink and it's not going to be there. A couple other things where you're looking for these microorganisms, you want also to swab your stretchers and beds, especially in the areas of where the connecting seams are. So that usually tends to be contaminated with fecal matter, and you will find that there. So Jagdeep is asking me, where would you drain IV bank? So depends on really on the facility. So you can drain it into toilet bowls. I find it does splash back, and it's not really the most pleasant thing to do. Other thing is using, you can use the basin. So we have used the macerator, the pulp product basins to drain, and then you just send it to macerator. But anything really you can use anything that has the wider plumbing, not the sink, the hand hygiene sinks. So just for an exercise purpose, when you guys go either back to work, or if you have in your own house, you can take a look under the sinks in the bathroom and your kitchen sink. So you will see that your kitchen sink has much wider plumbing there, because it is designed to handle all that grease and all the gunk from the food, where your hand hygiene sink is designated only for hand hygiene, and you shouldn't be washing your dishes in there. So if you're looking into these pipes, if you ever seen one that after they remove it and they cut through there, it's almost closed with how much material has grown in there. And also it does create a problem for draining as well.
Cornelia,
Hmm?
why is the mortality rate so high with this
Because we
bacteria?
don't have drugs to treat it.
No, it's because of the enzyme producing and the antibiotics and stuff like that.
And we don't have too many choices, so it becomes really a challenge, because by the time we start treating our patients, there does so much damage to their organs to their bodies, so they causes kidney failures. And you find the physicians are really caught between a rock and hard place in finding that fine balance to treat a patient or and try to get rid of this microorganism, and how do you walk that fine line without causing further damage. You will find this also with some of the TB treatments, that our patients just simply can't handle it, and you're trying to kill the microorganism, but you're actually ending up killing the patient with the drugs.
Okay. Okay. Thanks.
So no, we don't really, it's not a self-limiting disease, unfortunately. Once it is present in the body, it will destroy the host. If it is a pneumonia that is caused by CPE, you have to do your best to treat it. As I said, it is quite a huge challenge for our pharmacists and physicians um, to treat these patients. So it is usually, sometimes you can actually see and be present when these discussions do happen. So you can ask them about what are the steps, and it's not easy for sure. So I'm just gonna give you a 5-minute break if you guys want, so we can continue with this once you have a time to a little bit maybe use a washroom or have a drink or something, and then we can be back at 11:45. I hope you guys are not losing your weight because you're stressed. It's just because you're disgusted with the topic. All right, so are you guys all back and ready to move along to a little bit of antimicrobial stewardship? So this is just to give you a little bit of a flavor for that, and we are going to be dealing with this in great depth in one of the upcoming sections. So antimicrobial stewardship is something that has been more present in acute care settings. I hear it's taking some time, but it's also getting into long-term care facilities and retirement homes. I find it does depend on the connections and what hospital is your closest ally, and who is the infectious diseases physician there, and how are they seeing the access and availability of themselves actually to be able to help you and support you. It is usually it has actually to be a component of your antimicrobial resistance management program. So if you have antimicrobial resistance management program in place, there is antimicrobial stewardship as well. Usually you're looking into the team that is made up of infectious diseases physician, pharmacists, lab techs, and practitioners. And in terms of how does that usually look, we are looking into the infections, we are reviewing the antibiograms together and looking at the number of the infections that are in your setting that are caused by antibiotic resistant organisms. So that's where we come in play, and we are the ones that have all that information at the fingertips. So you, for the collection of that information, if you're, I'm sure many of you are doing, but if you're looking for some tools, I already said there is a line list that I put up for you, but there is going to be, I'm working on this line list to share with you, and you can download that and use in your day-to-day work, and you can easily extract these numbers as you go from these line lists. But usually what we are looking as practitioners, it's the surveillance that is first completed, but then also we are looking at the number of the patients that we find on routine cultures to be newly colonized. So you're looking at who are the new cases that we have identified. So that's how you're seeing whether there is a problem with the resistance and drug use in our own facilities. The problem with that is that you often have patients who are returning to us, but also sometimes you have patients that show up and from some other areas, and they're not necessarily in our catchment area, but they're simply our patients. So those numbers actually can skew your stats. So that's why it's important to collect all the demographics on your patients, so you can actually exclude them from if you're looking into your own numbers within your own catchment area or your own patient population. So when you're looking into antibiotic rates, antibiotic resistant rates, you're looking into the rate that is expressed per 100 admissions or 1,000 patient days. Most common would be your 1,000 patient days. So this is important to know how we are expressing the rates for MRSA. So it would be a number of cases per 1,000 patient days. So your patient days you will get usually from your accounting. They're the ones that have these numbers. We are not usually the ones that have these numbers. We are not the ones collecting that. So you have to go and ask either accounting, or there is Bedflow sometimes will be hosting these numbers for you. So you get updates on monthly basis. So for the financial purposes, usually accounting keeps these numbers and you can get it from them. And then you're entering into your spreadsheets the number of cases over 1,000 patient days. And that's how that rate is calculated. All right. So the surveillance in Canada is something that is good for you to know for your test. I can't see them asking you about this, but it's good for you to know. And also, it's good for you to investigate what is the surveillance in the States. Um, so there is a document that I uploaded. It's the image here, and you can look at that document. It's a really cool breakdown of what is actually happening in a period between 2014 and 2018, and then they published that in 2020. So what are we looking at through the surveillance is the bloodstream infection. So we are not looking at colonizations per se. We are always more interested into these bloodstream infections. And so you will, if you open this particular document, you will see that some of these infections are actually on an uprise. In particular, you will see with your VRE, and I already mentioned this in the past, it is in a close relation to stopping the additional precautions. And something to be said about that is as much as we think we are so good at routine practices, and we thought if everyone is aware the patient is VRA positive and we don't put them on additional precautions, the frontline staff would be adhering to the routine practices. It just proves that we are far from perfect in this world and in this role. So you will see that that has actually affected the number of the infections caused by VRE. So when you're looking into your MRSA, the bloodstream infection, look at the numbers. It's increased by 140% in 4 years. And that's predominantly in relation to the community-associated cases. So we are seeing that community-associated cases of MRSA are on an uptick. And if you're looking for where can MRSA in community be found, it is everywhere, but predominantly we find it coming from gyms. We have seen quite a lot of these coming from the balloon soccer fields where they have plastic turf. For whatever reason, it's a lot of MRSAs coming from linked to these particular locations. So that's something to think about. It tends to be also quite present in public transport. So clean your hands every time you touch something in case you didn't start frantically just pouring bleach over yourself once COVID came in. I'm surprised we are all alive and kicking with all the cleaning and disinfection we are going through. But it's about 20% of our patients that are diagnosed with the bloodstream infections that actually have died within the 30 days of diagnosis. So that's significant. Also, 20% of patients that die within the 30 day, that's a lot. Patients that die. And why is this important to us as practitioners? Because they are preventable diseases. It's not something that cannot be prevented, or it's difficult to prevent. If you're thinking of MRSA in particular, it is an organism that travels on hands of healthcare providers, and with improved hand hygiene, you should see reduction of MRSA. If you have hand hygiene that is sitting in about 80 to 90% of compliance, and you have MRSA outbreaks, your hand hygiene is not being observed correctly. Then we are looking into the effectiveness of carbapenemase, also that's been discussed in this particular document, and it actually has increased by 9-fold. Something also to be concerned about for sure, especially in light that we learned that the mortality rate in case of infection with these organisms is 50%. And the proportion of your multi-drug resistant gonorrhea, if nothing else is scaring you, there is something to scare you. It's the number of these infections have doubled. And then for our typhoid Mary, also we have now something to talk about is the salmonella that is drug resistant, and it's actually has been identified as a 3% increase. So when you're looking into your antibiotic resistant organisms, there is a list of these organisms that have taken a priority that we are focusing on, and they're listed in the on your slide here. So some of them you are quite aware of and dealing with, and know what is going on with these. Some of them may not be something that you have encountered. I haven't and seen some of these. I have never seen a salmonella that is drug resistant in my work. It's just something that is on a rise, obviously, but it is something to be aware of, because it is in a short period of time went from undetectable to 3% in 4 years. That's a significant change. When you're also looking at the numbers that we are seeing, it could also be in relation to improved surveillance systems that we have in place, and that we now, once we start looking, we are actually finding these problems. But also there is obviously with things like MRSA and VRE that we have been looking for a long time, seeing increase in these numbers is a sign that something is not working in the world of IPAC. So I've taken out of that particular document some graphs to share with you to see how the methicillin resistant Staph aureus blood infections are looking when presented in a diagram. So you can see clearly that you have an increase in these cases. There is no question about that. On the right-hand side, we see that over 4 years, 555 people have died from these infections, and that's 555 preventable deaths. So something to think about as you are leading into the world of IPAC. What can we do to save some of these lives? So again, there is your VRE, and you can see that the number is on an uprise significantly here as well. And we had 649 cases over the 4 years of the bloodstream infections, and then 202 deaths. So it's also important to know that if you look at these two slides, that there not all hospitals are participating. So if you look at MRSA, you'll see that about 65 hospitals reported, and in VRE, it's about 57 to 62. So we are not necessarily having the same database to pull from, but it's still significant to look at from the numbers as well. And then here is our carbapenem is producing enterobacteriaceae. So luckily the death rate is not as high as we are looking at MRSA and VRE. However, that said, it's also a possibility that some of these cases are going underdiagnosed and undetected in some situations. So we may not necessarily know that our patients have been carrying these CPE organisms that have caused an infection and they have died. However, if you're looking at the colonization, look at how high number that is. That's 292 cases of healthcare associated colonizations, and 73 of them are infections. And then, of course, C. diff, and that's interesting what the number of C. diff infections is actually going down over the years, and that's a good sign. That said, it's a lot of work that's been invested in control of C. diff. There's a lot of drive coming from the ministry. There is a lot of perks that are given to the hospitals that are bringing down the numbers. So there is a lot of benefits if you manage to get your numbers down. So again, it is, if you're looking at the hospital numbers, so take a look at the numbers that are participating. So in this particular case, it's about 53 to 68 Canadian hospitals that participated, but look at the number of deaths that are caused by C. diff. It is, I'm sure, I'm 100% sure that if you work in any type of healthcare facility, you have seen C. diff and you've seen death caused by C. diff. One of my first cases that I actually dealt with was C. diff as in my role of infection control practitioner when I started working years ago, 2 years ago. And so I remember with this particular gentleman, he has suffered a loss. His wife has passed away, and he was a little bit down and you know depressed. So ended up actually catching up some pneumonia and presented in our hospital. We treated him for pneumonia. And while in our care, he developed C. diff, and it was a, a gentleman that had barely spoken any English, so the two of us communicated with thumbs up and thumbs down. Every day I would walk by his room and look at him and show him thumbs up, and every day he would show me thumbs down. So it was quite heartbreaking for me to see him in such conditions. So in the end, we managed to actually discharge him home. So this is a man who had a life. He had a Tim Hortons at the bottom of his building where he would meet with his friends for coffee and just carry around his day. His son and the daughter-in-law were coming in and bringing him food, doing the laundry and things like that. So he was somewhat independent, really, didn't really need any assistance from outside beyond some of those household chores, which probably he could have done, but I think he never did it because he had his wife taking care of these things. However, when he was discharged from us, he went into a long-term care facility, and a year later he came back a completely different person. I did not recognize him short of recognizing his name. And he had all sorts of lines and tubes running into him and running out of him. And he had again repeated C. diff infection at this point, and sadly he did not survive. And so that's a story that sticks with me, and that's why I always think about C. diff as something that can be prevented, and we have to work hard um, to make sure that we are not causing more harm than actually helping our patients. In this particular case, it's, as I said, I shared this story with you, but it's been something that stuck with me for however long I've been in IPAC, and it's been probably now 15 years, and it's still fresh. So there is your C. diff, not as cute as it is in not in this little stuffy figurine as it when you deal with it. It is a disease that will make your patient febrile, and they will get completely dehydrated from the volume of stools that they're dealing with. It sometimes, as I said, it could be up to 20 diarrheas. They're very liquid, and they also cause skin breakdown, and that's a secondary problem with it. I posted a video to you guys about a fecal transplant and a patient whose life has completely changed as a result of this fecal transplant, and she got her life back. But a lot of people are quite queasy and not open to the idea of fecal transplant because it just sounds so not appealing to many of them. However, it is one of the tools that we do have in our toolbox, and every time you find that your patients are not responding to the treatment, bring it up as a discussion at least, and start talking about this, because people's lives are saved when we open our eyes to some of these unconventional treatments. So the stools are safe. They're collected from healthy donors. The problem is collecting these stools, because the requirements are quite rigorous. There is no traveling. They have to be healthy. There is certain criteria that has to be met to donate stools. So that becomes a challenge. And the other challenge is also the participating facilities that actually do provide this service. So you will see Michael Guerin would be one of them, Hamilton Hospital, St. Mike's does it. So there are a few hospitals in GTA area that do it. There is also someone I was talking yesterday about the synthetic. There is pills that are being developed that people actually can take orally to enrich that bowel flora, but also things have changed significantly when we started doing these stool transplants. They were introduced orally. Nowadays it's enema, so it's coming from the back door. At least it makes people feel a little bit better from the portal of entry, I would say. All right, so let's move along, get into the viruses. All right, so I'm sure you guys have seen pictures of viruses with COVID that you can't now close your eyes and not think about it. But what is really important for you to know for purpose of your CIC exam is to know that there is two types. So there's DNA and RNA viruses. They are double-stranded and single-stranded viruses. And then there is some that have envelope, others that don't have an envelope. So you just need to know the differences. And sometimes they would provide you with a list of viruses, and you have to recognize which one would be a DNA virus or which one of these is not RNA virus. So they would give you 3 RNA viruses and 1 DNA virus, and you have to be able to pick that one out of the crowd. So that's how the exam questions will be for you. So when you're looking into your differences between bacteria and virus, so this also can and will probably be asked from you. The differences in the size. Also, one does have a cell, the other one is a cellular organism, and it does require a host to multiply and replicate, of course. And then you're looking at, so they're going to ask you about an organism that's been identified. They have DNA and RNA. So you know it can't be a virus from there, because viruses have either one or the other. They don't have both. So those are some of the things that you may be asked in your CIC test. So what is a virus? It is a cellular form, and there are neither eukaryotes or prokaryotes as your organisms such as bacteria, protozoa, and parasites could be. It is an obligate intracellular parasite, so it is a parasite in a greater sense of what it is. However, it is defined as a virus, and they always require a host to reproduce. They do tend to survive and remain in the environment. However, they do not reproduce on surfaces. They need a host. They need us to enter our cells and start reproducing. They do contain either RNA or DNA. That particular RNA or DNA is surrounded by a protein. And sometimes you will find some of these viruses have envelopes. So in your CIC questions, they will ask you which of these is envelope or unenveloped virus, and they will give you a list again of viruses. So you have to know that classification, whether they are enveloped or non-enveloped. So, and then of course they're classified into different families in a similar fashion like bacteria is. So you will have them under RNA, DNA viruses, morphology, number of strands, and then whether they're enveloped or unenveloped. So when you're looking into your viral structure, you will see they have their lipid membrane, they have these docking glycoproteins. That's what we've seen whenever you see those little tips on the viruses. That's what those are. They have either their RNA or DNA, they have their capsid. So your capsid is actually the protective layer that surrounds and protects their nucleic acid, which is either RNA or DNA. And it's in place to protect from the harsh environment. So with the envelopes, they either can be a lipid or protein envelopes. And I already mentioned to you guys, it's either one of those. It can't be both. All right. So then you may be asked about some of these shapes. I will not play this video because of what we've been through yesterday, so I will just add this link to the rest of the links to take a look. But you will see that you have these icosahedral or spherical, so that's what you will see with your measles, with flu, with some of these coronaviruses. Then you have these capsids that are helical, sorry, the structures that are helical or rod shaped. And then you have these, I always think of them, they look like little screws, these complex built viruses. So of course we can't see them with the naked eye, and one would think by now that we know all about the viruses and their shapes, how much we've seen them in media. So how do they reproduce? So I'm going to tell you, this is going 100% going to be on your exam. So do know the process of how does a virus go through the reproduction process. So they always have to attach. So they do attach to the host cell. And then from there, once they attach, they penetrate into the cell. So remember that I was saying they always have to be within our living cells. Once they enter that cell, then they can start their process of replication. And usually that goes through, again, within that cell, they start synthesizing and replication of the host cell ribosomes, because that's how they work through. And then as the process of the reproduction develops, there is the one of the steps is called maturation, and it's basically reassembling the virus. So they have created all the bits and pieces that they needed, and now they're ready to be released as replicated and out of the cell and invade our body. So usually with some of these viruses, you will see like norovirus, for example, you need such a low number of viral cells to become infected, and yet we are shedding so many as we are going through the infection with norovirus. So it's our body that produces it. Okay. So again, I will post this video as well. I thought would be cool to share this with you. There are some of them are the very nice animations that show how viruses go through attachments and how they're penetrating the cells and replication process. So this is going to be a nice one for you to look at. But what is really important, and this is to know that the receptor is usually the glycoprotein that is a part of the virus. And then this is how the viruses actually enter, how they attach. And Mhm. This one? So can you think of a virus that would be remain dormant in a host's body for extended period of time? Herpes. Yes, chickenpox. Chickenpox is from a family of herpes. So any type of herpes virus actually does enter your nerve tissue and will remain dormant there. So again, the viral entry, so it's just broken down into more steps here. So the endocytosis, the entire virus actually gets engulfed by the cell. So that's how the virus enters into our cells. So the cell kind of swallows it, if it makes sense. And then there is the direct fusion where the virus actually fuses itself with the cell membrane of the host cell. And then with some of the enveloped viruses, they will take some of the host membrane with them. So you will find that they take your part of your cell with them as they're leaving. And then there is that nucleic acid translocation. That's another way of how they're entering the cells. So it's usually common for some of the non-enveloped viruses when the capsid adheres to the host cell membrane, and can be also done by the partial rearrangement. So the virus itself does some rearrangement itself to actually enter the cell, and then sometimes they do pass only their nucleic acid directly into the host. So they have different ways of kind of disassembling and assembling themselves. And so basically what they do, they use our host cells as a manufacturing business for them. So they bring the bits and pieces and assembly parts and create more of these parts. And then they use our cells to push and manufacture viruses for the little baby viruses, if that makes any sense. And then when you're looking into your DNA virus replications, so some of them that you will need to know are herpes, chickenpox, Epstein-Barr, and hepatitis B are DNA viruses. So those are the ones that are not RNA viruses. So, and you will find that herpes and chickenpox are from the same family, of course. So how do they assemble themselves? So back to that slide that at the beginning here. So this is where they start putting themselves back together. So they do end up with, usually with non-enveloped viruses, you will find that they will actually cause a death of the host cell. So it's called rather lysis. And then in some of the enveloped viruses, they will be budding through the host membrane. So they're kind of coming out of the host cell, where the non-enveloped viruses tend to destroy our cells that they are in. So they also use some lipid and carbohydrates, and they also have some kind of ability to get integrated into the host membranes. So there's a lot of things that are unknown to us in terms of some of these processes. How does this happen actually in a cell? But some of these are pretty clear, and it's very, very interesting to see how when they don't have a host, they can't really do much. It's not like bacteria that will survive on a surface, and sometimes the bacteria will also grow and multiply in environments such as, think about that Bacillus cereus that will grow and multiply in rice and then release the toxin. And when you're eating it, you're getting violently ill from the toxins, where the virus can't do any of that. Some of them do have tendency to remain viable on surfaces, but for the multiplication, they need a host. So with the DNA virus replications, so what they do is actually they code the RNA, the mRNA, so the host cell can make the proteins. So that's how they kind of, it's a two-step really for them to do this. So they use the host RNA, and then they create their DNA polymerase, and that's how they replicate. So it's versus RNA, these guys have two-step process of replication. When you're thinking about your DNA viruses, one of them, as I said, is herpes viruses, and there is an entire group that falls under. But the problem with these viruses is that they become a part of the nucleus. So this is where you see when you're dealing with some of these cold sores, and you see if you ever have it, or if you know someone who has it, you will notice that they tend to reappear in the same area. And that's because that is the nerve tissue that is affected by this virus. Usually you will find with cold sores being reactivated through stress or exposure to UV light, in some instances with immune suppression, and sometimes you just don't know, they do tend to reappear. And when you're looking at your chicken pox, for example, whoever has had chicken pox, they're at risk to get shingles at some point in life. So I just put you some of the examples here of RNA viruses. So I urge you to know these, because the questions that do come on your exam will ask you to find the one that's not RNA virus. So you will see, if you memorize as many that are RNA, you will be able to say this one is not RNA, and they will ask you also an opposite question to pick one that's not DNA or something along those lines. You guys need me to stay on this one for a bit? I'm going to move along. The slides are uploaded for you. You can take them when you need them. So with your retrovirus, it's what they actually do, how they function. They do tend to synthesize a single strand of DNA, and then they copy that. And once that DNA is copied, they enter the host cell, and it's kind of like once they do that, it's kind of like a recipe really for them. So they just continue doing this, what they're doing, because once they learn how to, and that replication becomes faster for them. So here is your DNA viruses, so which are again, you have to know just at least to list them and recognize them. I will also tell you that a good chunk will be designated to hepatitis serology. So I have uploaded for you a link to all hepatitis serologies. So do watch these videos and be comfortable in recognizing how does that work. There's going to be questions on your CIC exam about that as well. That's a larger section to cover, so we can revisit in a chat if you have any questions or you're struggling understanding that. That's just a big big chunk for you guys to look and get comfortable with. So in a way, how a human body responds and how do we mount immunity and what's the process with regards to immune globulins and so on and so forth. It's just something that you have to memorize, really. I don't know that I have any tricks for you. I had to memorize that. So when we get into the antiviral drugs, so you will probably see acyclovir quite widely in use in your facilities. That's one of the most prescribed for cold sores in case your patients do have shingles, so they tend to give them acyclovir. Then when you're looking into for treatment of HIV, those are usually a cocktail drugs. So it's not one drug, it's usually many drugs that are given. Some of them are actually inhibitor. They have inhibitory actions and characteristics. So they tend to be given in addition to antivirals. And then probably one that you all have seen or maybe even received is Tamiflu, and it's given for influenza. Tamiflu has its side effects. You will find a lot of people will develop diarrhea after they have received Tamiflu. So something to keep in mind. It may be a secondary infection and you could actually end up with another outbreak, but also to be aware that a lot of people do develop diarrheas on Tamiflu. And also, the sooner you give Tamiflu to the patient, sooner to the onset of symptoms, it has better effects. A lot of physicians will argue that it's not such a great change. It reduces the duration of illness for a little bit, but where it really shines is when you're managing outbreaks and you're using Tamiflu as a prophylactic drug of choice, and you're giving Tamiflu to your staff and Tamiflu to the patients that are not affected. That's when you see it really, really works well. So when we start talking about influenza here, so there is obviously, you guys know, there's three different types. We normally have been dealing with A and B influenza. So when you're looking at your type A and B, those are the ones that cause most of the epidemics and world pandemics. Those are the ones that are circulating in community. And there, of course, they're divided. The A viruses are divided into the subtypes. So you will have those H1N1 and whatnot. So, and then when the naming nomenclature comes, and usually they give them the name of the geographic area where it's first detected, and then you will see the year usually follows, and then they're identified by these H and N subtypes. So as I said, there is 18 different H subtypes and 11 different N subtypes. So we are looking into these subtypes and vaccine performance. It is kind of looking like a key and a keyhole where you have to find a perfect match to actually unlock the world of success to vaccines. With either cases of influenza A or B, you will find that they're present predominantly in humans, but they also can be found in other mammals. Most commonly, pigs is the ones that we encounter in our work. You will find that there is a swine flus that are coming around, but also bird flus. With the incubation period, this is important for you to know. Incubation period actually can be between 1 to 4 days. And when you're investigating cases, you're looking back as the longest incubation period. If you're looking into your outbreak investigations, if you're looking to declare an outbreak over, usually we are looking at the 2 incubation periods plus 2 days. So you end up with about 10 days from the last identified case that you didn't have any new cases in staff or patients, that you're then in that particular event you can declare outbreak over. It is a droplet transmission. You guys remember the chain of transmission that Kyle picked yesterday. He picked flu. We went through it. And so it is true droplet. The portal of exit is nose, mouth. Portal of entry is nose, mouth, and eyes. In some instances, you will find that patients who are immunocompromised, you will find they also tend to shed for a longer period of time. They are clinically improved and recovered. However, they tend to shed longer, and you will also in some of these cases find flu virus in feces. Yeah, so with COVID, and that's the problem. So it is a fairly long incubation period when you look at it, and then the disease itself in the milder cases is 10 days, and I find that's very confusing to general population when we are dealing with some of these quarantines at home, where someone who's been exposed ends up being longer quarantined than the ones that are actually actively sick. All right, so norovirus is a virus that you will find in your facilities, no doubt. It does have somewhat seasonal appearance, and it does have also a cyclical appearance as well. So you will find that every couple of years you will see that we see more of norovirus. It is one of those viruses that tends to come back, usually enters our households through the youngsters that you have in your household. They're the ones usually who bring it home from daycares and so on and so forth. It does present itself with vomiting and diarrhea. And there is, as with no other viruses, as with other viruses rather, there is no immunity with this particular virus. So you can be reinfected and reinfected and reinfected. There is some discussion that in older age we tend to when we get norovirus, we tend not to vomit as much as the youngsters do, but generally speaking it's coming on all ends from infected individual. The incubation period is very short, so and it's highly virulent. Remember I was saying you need only so many particles to get sick. So if you have a case on your unit, you will have more than one, no doubt. It just spreads like wildfire through your facilities. And the problem with this particular virus is that you start shedding the virus and sharing the goods before you're asymptomatic. And then an individual also can shed after they're recovered for about 4 weeks. So that's where the problems with this particular virus are, is that we don't necessarily see people asymptomatic, and it's not something that we are quick to isolate, of course, if they're not symptomatic. In some cases, just like I mentioned with flu, you will find extended periods for carrying the organism. So you will find that in some instances, people can actually carry it for about 6 months in immunocompromised population. It is, Sharon brace for this, it's an oral fecal route of transmission. So you have to ingest the virus that has exited through the back door. There is also some evidence that it can be actually aerosolized, and this is not to say that it's an airborne, but it does become aerosolized in cases where you are applying high pressure to fabric. So if you are if you had somebody who in your household, for example, a child that's been vomiting or having diarrhea and you're soaking that laundry, don't put a shower head on it because it will spray that and you can actually get it that way as well. These droplet contact precautions for the particular reason that does come also through emesis and it's not something that we get exposed through coughing, but it is through emesis. And usually we maintain precautions for about 48 hours after the symptom resolution. And for declaring an outbreak over, again, it is the incubation period plus 2 days. So it's 48 hours times 2 plus 2 days. All right. So now we are getting into measles, and I will tell you it's probably one of the viruses that has caused a lot of running in my previous jobs. Whenever we would find a case of measles, we tend to run down to emergency department to confine these poor souls, and it's a lot of work, and in particular with follow-up. I think Jagdeep was asking yesterday about these follow-up cases for the staff, so this is one of those really intense follow-ups when we have to capture a lot of people because it is an airborne mode of transmission. And with I'm going to ask you this so we can all try and get an answer. What do you think is the exposure? So when you're looking into your exposures for particular diseases, we are talking about the time that a person has to be in contact with a source to be considered exposure. So for example, you guys know, everybody knows, for COVID, it is 15 minutes without any PPE. So if I was to ask you, what do you think it is a time exposure for measles? Is Rosemary changing her mind as she's typing? Oh, okay. So it's actually exactly, it's -2 hours. So what this means in terms of exposure. So say if I was in your room and I left and you entered the room 2 hours after I left, within that 2 hour period, you're considered exposure. So we are not only looking into people that have shared a room with known case of measles. We are also looking at people who have entered that space after the known case has left. So that's kind of challenging to manage, and when you're doing the contact tracing in such instances, it's very, very difficult, because in most cases you'll find that our patients have made presence in emergency rooms. And emergency rooms, there is no rooms, it's just this open space. Sometimes there's curtain space, and there is really no clear location. So we can't trace who has been where. And then within the emergency rooms, often there is family members that come with their loved ones and they drop them off and wait with them. So it becomes quite a challenge to find all the people that have been potentially exposed. And it's a lot of work. Yeah, so it is exactly that. Even if you have been there for no time, absolutely no time, that's you're considered exposure. So the symptoms are usually fever and cough and coryza, and you will find that people actually have this maculopapular rash and starts usually on their face and does have a tendency to spread across the body. Humans are the reservoir. It is an airborne transmission that requires airborne room and negative pressure room. The incubation period, this is important for you guys to know. This may be also on your CAC question. It's 8 to 12 days. And how long are we keeping these people on precautions? It's for minimum of 4 days after the rash has resolved. So once that rash is gone, you want to keep them for additional 4 days on precautions. So what happens with your exposures? So there is different follow-up with your exposures. There is exposure for the patients that are within our facility. So the admitted patients, they are our responsibility. And then the individuals who have either been in this area through just by virtue of coming with their family members, they're followed up with public health, and this is why we have to give them all those lists of individuals that have been in emerge or have only been seen in emerge and who has accompanied them. And then for the occupational health, they follow up with staff. So it's a lot of work. Luckily, I find in my dealings with these particular cases, what happens usually is a child presents in a physician's clinic. Parents bring them in thinking it's an assumed maybe like a allergic reaction, a rash or something, and the physicians recognize it and they give us heads up and a call to IPAC department telling, I'm sending this patient, this is who is coming to you, and they're coming to be seen by the physicians in our hospital, for example. And then we actually have a little bit of ability to take a look at who is there and wait for them and provide them with a mask and escort them directly into airborne rooms so we don't have that exposure. So that kind of helps when they do that. Oh, and so I just wanted to show you, these are these complex spots. So that's one of those giveaway when you look at the patient, they have these spots inside of their cheeks. So then we are moving to varicella. So it is cause for chickenpox, of course, but it's also known as a human herpes virus 3. Humans are the reservoir. The presentation is usually generalized. So we'll find your patients will present with fever. They have the rash that is actually going through different phases. You will have this vesicular rash, and then it can become turns into papules and vesicles, and then once it starts crusting, there is end in sight. It is very uncomfortable, it's very itchy, and people like to touch themselves and scratch themselves. It is an airborne transmission. However, in quite a lot of facility, you will find that people will put these patients on airborne contact precautions because of a risk of exposure through the skin. And that said, under routine practices, we are trained not to ever touch any skin that is non-intact. So it would make sense, even if you just have airborne precautions and you're only wearing N95, that by your own risk assessment, you shouldn't be touching these vesicles or papules that are on your patient's skin. how long are we keeping our patients on precautions? Until every last one of these vesicles is crusted over. So you don't want any of those wet ones. And usually they tend to stay longer present in an areas that are covered or are just by anatomy of human body, they tend to stay moist and warm, so they don't dry as fast as the ones that are exposed to air. And the incubation period is 14 to 21 days. And when you are dealing with chicken pox or disseminated shingles, you want to make sure that it's only immune staff is working with these particular individuals. And this is where it is important to communicate this to the unit managers and your occupational health. So shingles, this is a reactivated chickenpox. Usually is found in people who either have, due to age, their immune system has weakened, or as a result of some underlying conditions. Usually it is affecting only certain areas and tends to be on the trunk of the body. You will find it often on the face. It is quite painful. People are complaining about having this painful burning sensation in the area, in the affected area. It can be localized, and when it is localized, it affects only one dermatome. It means it's contained. You don't need any precautions. You're returning back to routine practices and risk assessment. Do not touch these sores with bare hands. Don't expose yourself through that. But if it is disseminated and it does cover more than one dermatome, you want to have that patient on airborne precautions. All right, so now we're going to get into fungi. So what they are, they're eukaryotic organisms with a nucleus, so they're large, they're often visible with the naked eye. You will find them in soil and in moist areas. Usually, they are a problem for us in areas of hospitals or long-term care facilities that are undergoing construction. That's where you'll find the most of the issues with them. Some of them are beneficial. We use them to make beer and bread and cheese and some of the good stuff, and sometimes they cause lung infections and can be deadly. Mushrooms, yes, absolutely, yay. In nice omelet, right, Sharon? I just thought we are going to move away from grossing you out from food. So diagnosis of fungal infections is really hard, and it sometimes requires more than one person to take a look. Usually you need a physician, a radiologist to take a look. If it is a lung infection, they're presenting in certain ways on your chest x-rays. And of course you need your micro people who will tell you, yay, that's a fungi. So they do contain so I just want to make sure that you guys know what's a eukaryotic cell. I also have posted a video for you to take a look at that. So they're a little bit different than, of course, the others. So you will find that they do have a cytoplasmic membrane, they do have a cell wall, and they're important when you're looking into your diagnosis. It's important to know this. And we actually can talk about, I'm thinking I have another section that talks about the drug use for fungus. I think it's in section 7. So we will get a little bit more into that in a later date. There was a fairly big hoopla with one of these yeasts at Grand River Hospital in 2012. What there was a microorganism cell that came in. The patient came from Arizona, and presented with respiratory illness, and some of the tests were completed, and then eventually they have suspected that he could be a fungi that is in his lung, and they collected the specimen, and then the lab in the processing, instead of disposing the petri dish into the biohazardous disposal, they have disposed this dish containing the this fungus, the cryptococci, is they dispose it in a regular garbage, and it's been sitting there for a couple of days. So what happened, this fungus has potentially affected the entire hospital, carried on the air currents. They ended up have to, when they realized what happened, they had to evacuate their hospital. They had to decontaminate all their staff. So there was a third party on site. And if you ever think about any movies that talk about decontamination and hosing down people, removing their clothes and disposing their clothes and dressing them up in something they didn't come in, that was exactly the scene that was actually taking place there. They had to dispose of most of their laboratory equipment, because if you look at any of the computers or anything that we use in day-to-day operation, they have all bunch of nooks and crannies and crevices and a lot of little engines that are propelling and cooling down these machines. And there was a huge risk that this particular fungi could end up in equipment. So there was a huge financial loss to this particular hospital due to contamination with the cryptococcus. There are a couple other things that you can find them in is your candida. Usually you can find them in mucous membranes, in mouth. They can be also part of the vaginal wall. They do cause dermatitis. So some of those are quite ubiquitous, and you can find them around. Others are causing a lot of damage and cost a lot of money once they are off leash. Okay, so then we are getting into molds. So they are visible. Usually you can see them if you have had any cheese or bread in for a little bit longer. I find a lot of additives that are added to the foods to prevent molds from growing. But if you make your own bread and leave it out there, you will find that it will grow some fuzzy tenants on it. Usually it does have this fuzzy appearance, and that's your hyphae that is part of the mold, and that's how they transport. And from point A to point B, they kind of fly or transport on air currents as well. You can also transport them by cutting into it or by your hands. You will find that some of them do multiply asexually by fragmentation. So those are the hyphae that they use to reproduce. Molds in healthcare settings can be quite challenging if you are going through construction. That's where you'll find a lot of this aspergillus species. It does cause aspergillosis. It becomes a huge issue for patients, for your cancer patient population, for burn units and things like that, where these molds do affect your patients. So it is important, critically important, that when you are undergoing any sorts of construction, that you are part of the committee that is reviewing your contractor. You want to inspect the hoarding of the site, and also you want to make sure that the airflow is adjusted, so you're not bringing anything from the construction site in any of your sensitive population units. So some of these fungi that are dimorphic in nature. They can grow either as molds or yeast, and that you will find that will depend on the environment you find them. So they're if found at temperatures about 25 degrees Celsius, they will take a more of a mold-like form, versus temperature of 37 and above, they kind of become more yeast-like. So some of those are histoplasmosis, blastocyst They cause usually the chronic skin infections. They can cause some of the pneumonias and pulmonary lesions. And there is something that I just wanted to make sure you guys are aware. So some of these have changed also their classification. So pneumocystic cerini has been identified prior as a parasite. Now it's actually recognized as a fungus. And I don't know if this is going to be mentioned in your exam, but usually when some of these changes do happen, they tend to bring that up and check if you're keeping on top of the changes. So that's what there is as a news. So who is at risk? I already mentioned your cancer patients and your burn patients, but there is a full list of the patients that are at risk. So patients who are actually receiving chemotherapy. Transplant patients are really big population that we have to think about. Usually we keep them alone in their own unit. We don't tend to put them with the rest of population. So if there is any construction happening on that floor, you have to be aware of that. But also know that even if there is an outdoor construction, you want to make sure that your patients in these units and the airflow is actually pushing out, not bringing anything in. And for these, when you are bringing fresh air intake, depending on the hospital, so some of the new hospitals have 100% fresh air intake, and they also have HEPA filters. So nothing for you to worry in that case. But if you're in an older facility, definitely get involved and find out what's going on with the construction site and whether you're putting your patients at risk. So as I said, there is your patients that are on long-term antibiotics. So I find also with HIV patients, I remember where I mentioned this yesterday to you, and I saw my first candida in a person. It was an HIV actually patient that was AIDS patient. People who also tend to be IV drug users, they're also at risk for some of these fungal infections. And then something to keep in mind, so this is the same case that I just mentioned to you, people who travel to endemic areas. So we don't necessarily see all of these fungi in Canadian environment. However, people do travel and can bring some of these microorganisms to us as they get exposed at the other places. So how do we identify them? Usually depends on what are we looking at, but somebody has actually to take a look and recognize them by shape. Usually we can also grow them and what is commonly used is a blood agar, and they do need temperature to incubate, and it's usually 25 to 30 degrees Celsius. And it can, in some cases, can take few weeks to grow this particular fungi in a lab setting. Sometimes you need a more specific media to grow, and that becomes a bit of a challenge for your labs, and then they have to transfer these specimens off-site. So those are some of the ways how we identify them. I think for the CIC part, you probably want to be aware of those aspergillosis and that type of a thing. Okay, so how they commonly represent, you will see them as usually as pneumonias. You will have these people that have cough, and it's kind of, sounds very it's not a deep cough, but it has this attached breathing pattern to it. So it's almost like wheezing sound that comes with it. Again, we are not part of diagnosing these patients, but it's just something for you to know. It can also affect skin. You will find that often it does cause itchiness on skin. It can also cause some of the draining rashes on the skin, and it does affect also your sinuses and nasal. So sometimes you will find also that people have some of this fungus on the scalps of their heads. So those are the things that you may come across. So they do also affect some of the central nervous system. They can cause meningitis, and they do commonly cause urinary tract infections. So that's something to keep in mind as well. Usually you'll find after a prolonged use of antibiotics that fungi will set in urinary tract infections. So you end up with yeast infections. So those are some other of presentations that you may come across. So this particular one that I mentioned before to you that affected the lab in Kitchener, it was imported from Arizona. So you need to know that some of these we don't have in our country and we don't have anywhere in Canada, but they can come to us. So there are some lists for you that you can take a look at where they're coming from. I'm trying to think, would they ask you something like this? I have never come across these questions, but something for you to know. Then we are getting into some of the parasites that can also live your in your scalp as well. So those are your external parasites. Again, where do we find them? They're predominantly found in environment. Animals can carry them, we can carry them, and most common ones that you will come across is your Candida species. So that's, I think, important to know. What are we using for antifungal therapy? I don't think anyone is going to ask you this on your test, but fluconazole is quite common to come across. If you're reviewing your patient's charts, you will find that one quite frequently in use. And now we get for more topic for Sharon. We are going to be talking about parasites, and they break down into endoparasites and ectoparasites. So your ectoparasites are the ones that live on your skin or your hair, or could be also found in the environment. So people tend to get quite squeamish when they see some of these. You can find them also as being living in our blood or in our gastrointestinal system. And there is different species. And Sharon, everyone gets so upset with these bed bugs. The thing is that they really don't do anything to us as humans. They're just there. I had a professor who had his pet bed bug, and he kept him in office, and he would let him out to feed on him once a month. And then he was reducing the or expanding the period between the feeding periods to see how long this little fella would survive. Eventually, by the time of I finished my course with this particular professor, that his bed bug has passed away, sadly. So one of the topics that you will 100% have on your exam is scabies. So do get to know what it is. They will not have a picture to identify it. We are never asked to do so, but you need to know the process and how is it spread. So it is usually you get the female who tends to get in between the skin and kind of starts, it's the top layer of skin, and she starts burrowing in to lay the eggs. The easy way to spot it, it's usually between the knuckles of one's hand. They tend to also be more present in moist folds, so you will find it under armpits, in female population under breast, but also in any skin folds that we may have. And I know Sharon is not going to have any skin folds by the time we are done with micro. So she is going to be so skinny because she can't eat anymore. So what happens when these larvae actually enter the bodies? So they start laying eggs, right? And then after, from the egg, the little larva actually hatches out, and then they grow into such a beautiful name for this little creature. It's called a nymph. And then they continue the reproduction after they grow into this adult form. And so one of them always produces more than one egg. It's not one egg, it's not like a chicken, so they tend to lay more eggs, and the more eggs produce more larvae, and more larvae create these new nymphs, and so on. The process keeps going and going. For you um, to be involved with this, people will usually call you and say, can you come and take a look at this? Is this scabies? It's not our role, again, to deal with this diagnosis, but you need to know what's the growth process, and how are they going through their stages, and also what needs to be done to control it. As far as the diagnosis go, you will see that the physicians will be ordering skin scrapings to send that to the lab and have it tested. The treatment for it is usually, you will find, I find that a lot is the permethrin is in use, and usually you will apply it below the chin, and it goes on intact skin, and it has to stay there for minimum 12 hours to actually be working and be effective. The problem with some of these things is people don't apply it properly, or they wash their hands and they remove the actual medication, so it's not effective as you would want it. And then it is actually, strangely enough, it is routine practices, and I know a lot of people get um, quite upset with the scabies, but it is routine practice. And then the only time we isolate the patients for is in case of Norwegian scabies. So, and that's when you have this uncontrolled growth, because in some cases where you have people that either have dementia and they don't feel the itchiness, so they go underdiagnosed and end up with this crusted scabies version. So you will be asked, I'm sure, about scabies, and so get to know a little bit more about these guys. So the bed bugs, that's what Sharon was dealing last week with. She had somebody that brought in bed bugs. Usually they travel on clothing. They do not live on humans. They will come and feed off humans, but they're not sitting on our skin. They tend to live in mattresses and clothing. And then if you ever go into a hotel, I'm going to tell you what I do just to creep myself out. If your hotel room has wallpaper, just see where the seam is, and sometimes these wallpapers are lifting, so peel that off, and you will see fecal deposit from the bed bugs, and it will tell you whether that hotel has been ever dealing with bed bugs or may be currently dealing with it. They do tend to have extended rather life. They can survive without the blood meal for the long time. I already talked about my professor who had his own little pet bed bug, and that's where you will find them. People do get quite excited about the bed bugs, but they are not known to be a part of any infectious diseases affecting us as humans. Lice, there you go. Those are other of the parasites that we as IPAC can be asked about. There is different types of lice. You will find the head louse or the body louse or the pubic louse. And the what is important as gross as it is, I think pubic lice do not spread any diseases. It's the body lice that you have to be concerned with. And they too go through this process and sequence of hatching. They get attached to a hair on our body, and that's where they lay the eggs. So you will find sometimes people will show you they have these white little buildup on the shaft of the hair. That's usually the eggs, and from that egg they do develop through a process of actually going through three stages of nymphs until they get adults. And then from the adult stage, of course, they again are able to lay eggs. And it is usually you need a very close contact with either a human that does have lice or with their personal belongings that can be infested with lice. Overnat, you do want to know. I know I want to know. I'd rather know than not know. So now we are going into some of these that tend to live inside of our bodies, and they're the endo parasites. So you will find that some of them will live in our blood, some of them will live in intestinal part of our bodies, in gastrointestinal system, and some of them you will find in skin or tissues. So that's where you will find some of these little guys. So pinworm is probably the one that you will find most around, and it's quite common. It tends to be present worldwide. There is no specific, it's not endemic to one area or the other. It does tend to affect more the younger population because of their hand hygiene and inability to control themselves from touching their bottom parts. And again, Sharon, this one is for you. It does go back into the mouth, and it's this happy cycle of oral fecal contamination. When you see somebody complaining of anal itching, it's a good guess that they do have a pinworm, and people do tend to auto-infect. So they do touch their back ends and not clean their hands, or get touching foods after that and self-contaminating by ingesting the eggs. The test for it is actually quite interesting. There is the Scotch tape is applied to one's anal end or anus, and then that's been sent to the lab for testing to identify if there is any actual eggs present in the anal area. That's kind of fun. Then there is the next one that you will find predominantly in the States, and it's strongyloides. I can't really pronounce these things ever. I always butcher them. So usually it is found in humans, but it's also dogs and cats can be carriers. And as you see on this image that I put for you, it does have a part of the cycle is actually in the secondary host. It is usually acquired through skin, so they do penetrate through our skin, and it's coming from contaminated soils. So what happens is the adult female releases the eggs in the small intestine, and then they hatch in there, and that would be your first stage. And then it's excreted through the feces. And then some of them will actually develop in that area, in that through that process, and get re-enter the skin. And some of them will actually go through the second stage, where they go into the penetration of the bowel mucosa or perianal skin, and are able to just maintain that one host cycle. When you're sending the stool for ova and parasites. And again, routine practices. As much as that grosses you out, it's routine practices, no additional precautions. So there is the tapeworms. And I'm sure, Vernette, some of those young ladies that went to get their butt implants, they may also have been buying some of these off Amazon as diet. So we had maybe 10-ish years ago, maybe a little bit longer, it was quite a craze among the models to buy some of these tapeworms from Amazon and intentionally ingest them for to maintain their slim figures. Not that I would ever do this. I just can't imagine picking up a tapeworm to keep my slim figure in check. But there they are. Commonly, you will find them as hosts to be cows, so they're coming from beef, or your pigs, so they're coming from pork meat, and often you will find them in fish. So Sharon found a way to promote our IPAC program. Amazing dietary approach to the to the IPAC program. I should probably share that with the college. So this is one of the perks: losing weight due to stress and the lectures we are getting. So it is, as I said, quite common to be acquired through some of these meat products that are not properly processed. And it is quite actually interesting, because you get people get diagnosed as they're shedding these parts and bits of pieces of these tapeworms. So you'll find them in the feces. Usually, it is quite common found in the areas that are having a very poor sanitation. So malaria is definitely going to be on your exam. So be quite comfortable with discussing this topic, and be comfortable to know the process. What is really interesting, I have seen quite few cases of malaria in my work. We don't isolate the patients that come with malaria. It is always imported. We in Canada do not have the particular mosquito that does carry the malaria plasmodium rather. So you will find that people will come in, and it's always imported cases. The incubation period can range from 7 to 30 days, and that's kind of a little bit on the longer side. But you always, when somebody presents with signs and symptoms, you always have to ask them about the travel history. And there is the test is called a thin and thick blood stain. We will cover more of the testing piece in section 6 when we get there. But as you can see, it is a quite complicated process of this particular parasite. So it is carried by the mosquito, and then once the mosquito bites the human host, that's how it's being deposited. And it goes through actually through the liver stage, where it does affect the liver. And then it goes into the blood stages, where it's replicating and transporting through the blood. And once that it's called actually a schizont. It's what does actually does rupture, and then it goes into this gametocytes part of the process of multiplication, and again it's transported through the mosquito. So you have to have this particular mosquito that does transport the parasite. It's a complex. So the parasite has a stage that is living in the mosquito, and then a stage that does live in the human. So you have to know that both are required in order to transfer malaria. So we don't have that in Canada, but you will see random imported cases. One of the celebrities that gets malaria on regular basis, if you want to know, ladies, is George Clooney. And if you still find him cute, just so you know, he has had malaria before. So that's as far as goes our uh, big section of micro. Is there any questions that you have for me that you would like me to answer for you? Or is there anything that you have any concerns with? Or is there anything I would help you through this particular assessment? Okay, so yes, it is quite heavy, and just I want to make sure you guys know that there's going to be a lot of questions in your exam about the micro piece. So I'm going to show you, I have this particular book that I refer to when I'm kind of flipping through. You see my book is old. This is one of the previous editions. I think mine is 18th, and now we are at on the 20th edition. Some of the information does get updated and introduced. However, it's one of my go-tos whenever I have a quick question, or I need to remind myself of what is the incubation period. That's my go-to. If you don't have this book, uh, CDC has amazing resources to speak about all these communicable diseases. But for your exam, I would suggest, or as I said, for any other work that you need in your infection control job, this is a good little booklet to have.
I didn't see the name of the book or the title of the book. I'm just capturing a picture here. Thank you.
No problem. So I also have posted these links to our main web page. So this is where you can see the links where to get these books. Other book that I don't have in print that I use quite a lot when I'm doing my own research, when I'm preparing these classes, is the Red Book. There is a link to that. And of course, you cannot pass your exam without your APIC textbook. And they all cover different perspectives of these microorganisms, and talking about the infection control, what are the hosts, what are the modes of transmission, and things like that. You guys have anything that you would like me to address before we part ways today? Oh, so your IPAC midterm is at the end of the week 8. So I'm going to tell you this, there's going to be a quiz. I still didn't complete your quiz. As we are going through, I want to make sure I give you a fair opportunity to answer these questions. So I don't want to put anything in there that we didn't cover. And as I said yesterday, I'm building it to replicate format of the CIC tests. So you will have a feel of what can you expect when you start, when you write your own exam. So it's at the end of the week 8. I will open it to you for that entire week, so you can actually access entire week and write it. The caveat to it is once you start writing, you can't take a break and start tomorrow, for example. Once you decide to write it, assign your time and get yourself a quiet space and write. If you find you are having any, if you find that you have any problems with your exam, or just let me know. If you find you're struggling with any of the topics that we have passed, I will tell you also, let me know. I'm here to help you. I want you to pass this course, and I most definitely want you to pass your CIC and get your 3 little letters after your name, and you can proudly show them off to the world. So I'm here to help you get there. The midterm is going to be multiple choice. There's going to be some matches. So I will give you say, for example, a disease and match this particular disease with its causative agent would be one of those. So your APIC textbook, you can download in PDF. Somebody asked me that last night as well. You can access when you have purchased the access to the textbook. You see it's kind of an HTML version, but you can print it as PDF and save it as such. Whatever you guys do with this PDF, just be very careful. You don't want to get in trouble with some of these copyright issues. Don't post them on our IPAC page, so try avoiding that. Yes, so when you get into your immunology, there is a part that you will definitely have to know. So you will have to know the difference between innate and acquired immunity. You will have to know the basic principles of how does body respond to some of these foreign objects. You will have to know some of that acquired immunity in terms of what is that we acquire through exposures versus immunity that is acquired through the vaccinations. You also will have to know your immunity when it comes to hepatitis. So that's going to be 100% on your test for CIC. So you'll have to know how does hepatitis affect our body? How do we respond to it? When do you have the immune globulins develop? And when you start looking into your IgGs and IgMs, so get to know what are the IgMs, what they stand for, what are the IgGs when they do develop in hepatitis. So there's going to be 100% questions around that. I remember these very, very clearly on my test, and I know all my colleagues that we talk about, everybody had hepatitis questions on their test. And I have posted links in the discussion board to take you to CDC page that I find explains this quite nicely, and you can actually review and stop and take a look and see how these immunities work. There is always some questions about the delta hepatitis, definitely hepatitis A, hepatitis B, hepatitis C. So definitely some of those questions will come up. Anything else? Let me just pick it up here. So I'm just sharing the screen to show you some of these links that I uploaded for you guys to take a look at. Oh yeah, so this Weber training, this is a really great source of access for you to free webinars. So what they do, any webinar that's been developed and shared through them that is over a year old, it's available for free. If you sign up with them, they send you invites for some of these that are also free in real time, so you can sign up and access that. Where is this? There are some of the reading materials here for you as well that you can take a look. Silvernet, there is your UTI information with regards to diagnosis and when, what are the standards around it. And here is what I would like you to start a discussion here. So this is a really big part, and we simply wouldn't have time to cover this in our session. So do start talking about the coronaviruses and emerging diseases so we can cover some of this in a bit more depth, because this is definitely going to be a part on your exam, so we can cover that and share some of the knowledge. And here is the forums that I shared with you guys as well. Okay, and so there's links to videos that I uploaded yesterday, and I will bring the ones in from today. I think this one is pretty cool actually. I kind of like this one. I'm gonna share this with you. And on your CIC exam is 150 questions that they're there. Sometimes these questions are test questions and they're not counted towards your mark. It's about, I think, 20 or 25 questions that are not counted toward your mark. So you can see that it's quite in depth. So I just kind of like this video to show you how the microorganisms are in comparison to size of a human body, really. So there is some of your universe scale. You can take a look at that at your own. So there is your pollen size, chromosome, lymphocytes, and then size of yeast and red blood cells and things like that. So there you go. There's some fun things to look at as you go through these links that I shared with you. So Anita, I don't know the answer to this. I actually asked Leonard yesterday, and I know he's been bringing up this to the board of directors, that all the challenges that we are facing with the technical issues with uploading materials and managing and keeping these materials accessible to us after the classes are up for a few days, for a few weeks. They take them down. It's automatic process that does happen. I asked Leonard if he would be able, prior to the test that we have at week 8, if we can upload some of these videos back so you guys can have access and refresh, because that'd be really nice if we could accommodate that. And then also, if that would be something we can maybe do towards the end of the class, so you can have another opportunity to remind yourself of what these classes were. So I'm waiting for Leonard to get back to us and see what can we do to help you with this, because it is quite heavy material. It's a lot of information, and for whatever reason, the system itself starts just taking down after 2 weeks our presentation. So Leonard is working on bringing this back up for us. So thank you guys for attending the class today, and have a good weekend, and I'll see you in the chat room. And if you have any questions, I have posted my other alternative email, which is my personal email and my phone number. If you have anything you want to ask me, please feel free to connect with me. Yeah, so you can download the presentations. However, the presentations that I post for you, they don't have, unfortunately, recording. This is a different file that they have to go through and create after we are done recording. Right. Thanks, guys. I'll see you Friday, and then next Friday we'll do Friday, Saturday again. So that's another big chunk to put behind us, and then we can take a breather for some time and then carry on. Okay. Thanks, guys.